Mary Ann asked me to address legislation of the third path variety. Obviously, they are active at both the federal and state level. They advocate legislation which will institutionalize palliative care across all care settings. My goal this afternoon is to provide an introduction, some elaboration on their agenda, especially at the federal level. We are looking at an agenda of revolutionaries, those who advocate for sweeping changes in existing laws and methods of delivering health care services. By design, this movement progressed slowly for decades, and I call your attention to two birthday celebrations that occurred, that those in the know celebrated last summer. You remember the promises that we were all given by the designers of the Great Society around 1965. They were celebrating the passage of two major pieces of legislation, the Medicare bill and the Older Americans Act. Senator Dole and President Johnson were crowing at their success in passing these two big government programs for care of the elderly. Medicare was originally designed to provide limited medical care for those over 65. The Older Americans Act established the Administration on Aging in 56 state area agencies on aging, which oversaw various senior services like Meals on Wheels, senior centers, adult daycare, transportation services, to name a few. So innocent in the beginning, but these two programs laid a foundation for dependence on government. Government, which has now undertaken to gradually transform our traditional healthcare system to healthcare based on principles of bioethics, the new player on the block, which burst onto the scene in the 1970s. Let's take a look at the types of legislation third path proponents have in mind going forward. First, a bit of an overview. Tom Dashley, who was nominated by President Obama to be the head of HHS, but withdrew because of opposition, recently posted an article on the Health Affairs blog where he makes these points. Big data and electronic health records will make for a bigger transformation of healthcare. Hospital services, many of them, will be brought to the home with virtual visits using mobile healthcare technology. Pay-for-service models will be replaced by delivery reform models using value-based care. Diane Meyer of the Center to Advance Palliative Care commented on a major Institute of Medicine report that came out in 2014. In her comments, she offered these indications of where they are looking for change. People with serious and chronic illnesses and indeterminate prognosis will be surrounded by a new philosophy of care. Those with dementia, frailty, functional dependence, mental illness will need serious long-term attention. Acute care will be costly and therefore will be considered waste in the new models of sustainable medical care. That 2004 Institute of Medicine report calls for universal palliative care. This will require universal education and training of the core component of palliative care, a coordinated interdisciplinary team of providers, the physicians, the nurses, the social workers, the chaplains. By the way, the chaplains aren't your parish priests. Your parish priests need not go to the hospital. We have trained chaplains. I've had an interesting discussion with the man who was our pastor who totally agreed with me. Everybody's going to be educated in the principles of palliative care. The key components include control of pain, symptoms, and side effects, plus psychosocial and spiritual support. Much of the education process is about teaching communication skills. because palliative care relies heavily on communication during goals of care meetings and family meetings. Palliative professionals are taught how to help patients make choices consistent with their values, but those professionals are not above using motivational interviewing techniques to guide those choices. Trained palliative professionals will be proactively trying to identify those whom they can direct toward the palliative services, those with functional dependency, pain, cognitive impairment, exhausted family caregivers, behavioral health risks, even poverty, housing, food insecurity, lack of transportation, and literacy challenges. This is all in the Institute of Medicine report. The IOM report recommends Medicare and Medicaid coverage of patients' social needs or a type of wraparound support. The organizational mechanism to make that happen is floating around out there, as Stephanie has outlined. Here's an example of expanding palliative services you might not have thought of. Community Catalyst writes about their new initiative to get Medicaid to pay for housing costs for certain patients. Center to Advance Palliative Care's Diane Meyer believes that a palliative care program must network with community social support services because socioeconomic factors should be an integral part of palliative care. Working with community social services is just another step in their agenda to remove us from curative medical care. To quote Diane Meyer, as access to palliative care moves beyond hospitals to home, long-term care, and other community settings, the ability to integrate social and medical support services will be critical to the success and sustainability of these new delivery and payment models. Oh, no. Back. 2. Number 2. 1 more. There you go. Okay. And I'll tell you where a little bit about the lobbyists and who they are lobbying. Several broad national coalitions have been organized to lobby for this legislative wish list. There is a thing called the Chronic Care Working Group of the U.S. Senate Finance Committee is charged with overseeing policies which affect care of the Medicare population, and it's received letters from CAPC, Coalition to Transform Advanced Care, the National Quality Forum, and an array of hospice and palliative care organizations. Bottom line, they all want earlier access to palliative services. I think, as I mentioned this morning, CTAC was founded 5 years ago by former AARP President Bill Novelli and Tom Koutsampas, who had been associated with Compassion and Choices, I believe. CTAC is an especially well-organized and effective advocate for federal legislation and regulation. CTAC publishes an advanced illness policy agenda, so they announce what they're looking for. A summary of the CTAC proposals are categorized in 5 major areas. Preference-driven care, translation, raising awareness and use of advanced care planning and advanced directives. 2, delivery system reform, translated, payment changes based on quality and value. Caregiver education, consumer assessments, and encouraging community support services. Professional engagement, training of professionals in palliative care, and of course, more research, more government-supported research. We spoke to you this morning about CTAC's emphasis on advanced care planning and how they go about defining quality and value. CTAC has formed a lobbying group called the Patient Quality of Life Coalition. Members of this coalition came together to advocate for desired palliative care legislation during a very well-organized lobbying day summer before last in July of 2014 Along with the usual hospice and palliative care suspects, there were several Catholic healthcare organizations in this lobbying group, including the Catholic Health Association, Catholic Health Initiatives, Trinity Health, and members of an umbrella group of about 20 Catholic healthcare organizations called Supportive Care Coalition. CTAC helped convene a Senate Special Committee on Aging Roundtable in May 2014. Bill Novelli took the lead in delivering remarks pushing a policy program he called Advanced Care Project. They have an ongoing, long-standing goal to end the debate that raged before passage of the Affordable Care Act. You recall when Sarah Palin used the term death panels to describe a section in the House version of the legislation which would reimburse end-of-life counseling sessions with doctors, nurses, social workers, community-trained facilitators as a medical expense. Whether or not the patient wants certain medical treatment, filling out the pulse form. As I mentioned earlier, a major part of educating palliative professionals is in communication techniques that will coax the patient into making life-limiting choices. Medicare reimbursement for end-of-life planning discussions would institutionalize the pulse form across the country, and that goal is now a reality, going to be a reality by regulation, not legislation. They have quietly changed Medicare reimbursement codes. There are 2 new CPT codes that will become effective first of the year for goals of care conversations with a physician or any other qualified professional. These codes will go into effect along with some others first of the year. Although no medical treatment is given, Medicare will pay for annual end-of-life discussions with a patient, plus another whenever the patient's health condition changes. Another regulation change suggests more attention will be given to chronic diseases. This year, the Center for Medicare and Medicaid Services finalized new codes to provide reimbursement for the management of chronic care services. I'm going to give you a rundown on 2 of their most important pieces of currently proposed legislation. It's important to be aware that at the committee level, the substance of these bills or any of their other bills could be folded into another piece of legislation, but right now these are the 2 pieces that have been introduced and are pending in committee. I think you mentioned one of them. The first one is PCHETA, the Palliative Care and Hospice Education and Training Act, PCHETA. It establishes education centers to develop and disseminate curricula relating to palliative care, train specialists in palliative care, support continuing education in palliative care for generalists, provide students with clinical training in sites across the country, support the training and retraining of palliative faculty, educating and credentialing across the board. I just looked through the legislation, and these are things that I could immediately pick out. There are quite a few things in it, a couple of the others. It authorizes funding for up to 24 palliative education centers at medical schools to provide short-term intensive courses. And it authorizes formal retraining for mid-care physicians. And the subsidy and the training is not limited to physicians. Advanced practice nurses, clinical social workers, pharmacists, psychology students, they can all get in. The Care Planning Act, which Stephanie mentioned, it was introduced by Senator Warner from this state and Senator Isaacson from Georgia. It will create a new Medicare and Medicaid benefit called planning services for those with advanced illness, including a team-based discussion of goals of care, values and preferences, explanation of disease progression, exploring a relevant range of treatment options, and documenting a plan of care. This legislation directs the Secretary of HHS to develop national quality forum measures to evaluate the quality of services, treatments perceived versus outcomes. The National Quality Forum wants their performance measures to be the lever, which drives the kind of change in healthcare technology and delivery of service needed to achieve their goals. The Care Planning Act creates a default standard, almost mandating the use of advanced directives and the execution of POST, portable doctor's orders. It authorizes grants to develop decision-making materials and maintain a website to explain the standards. CTAC wants to control the quality of advanced care discussions and adjust payment to providers accordingly. The Care Planning Act also addresses circumstances under which providers do not comply with a documented preference. The overall goal is to make payment predicated on whether or not the patient was asked his goals and then whether the treatment met those goals. CTAC argues for the need to have quality metrics which assess whether treatment met the patient's goals. All of these bills consistently provide financial support for the training of healthcare professionals in the philosophy of palliative care. One of their current focuses, and one of the things these bills do, is make sure that all of the members of the palliative care team are paid for by the government. Philanthropies still pay for about 50% of a hospital's outlay for palliative professionals, because yes, the doctor gets paid, yes, the nurse gets paid, but the social worker and the chaplain and the other folks aren't currently being paid, so they're trying to get that changed so that that authority is in there. Care Planning Act goes a long way toward that. In general, Senators Warner, Isaacson, Hatch, and Wyden, and Representative Blumenthal are probably the closest friends that the Third Path movement now has in the Congress. So in order to be watchful about legislation at the federal level, I would recommend that you watch for and beware of whatever they introduce and try to promote. The 4 senators make up that chronic care working group of the U.S. Senate Finance Committee. They take advantage of our ignorance as well. 2 pieces of legislation, one passed in the last Congress and another one now proposed. The first, Impact, which improving Medicare post-acute transformation. A major piece of Third Path legislation breezed quietly through the Congress last year. It was introduced in the spring and signed into law in the fall. It followed a process reserved for non-controversial legislation. Under suspension of the rules means that a bill is raised on the floor, and if a single member objects, then now it's required to have 2/3 majority to pass. In both chambers, no member objected, and Impact was quietly enacted into law by voice vote without a single roll call. The fact that not a single senator or representative objected to this bill tells us that we have a lot of educating to do. As I said, the bill is called Impact. It's designed to establish a uniform system of assessing post-acute care to redesign payments across skilled nursing facilities, inpatient rehab facilities, long-term care hospitals, and home health agencies, all these disparate types of things. We're going to try to standardize them. The idea is to develop ways to measure in common terms the services provided by these disparate type of post-acute care facilities so Medicare can assess them, impose standards on them, and eventually determine which post-acute care settings are appropriate for the patient. Huge cost savings are envisioned by its proponents. An important piece of follow-up legislation to Impact was introduced this year. H.R. 1458. It was introduced by Representative McKinley in West Virginia, and it's called Bundling and Coordinating Post-Acute Care. here's the thing. This bill will provide the controversial piece that they had to leave out of impact in order to get it to sail through quietly. What is that piece? This bill would give control of post-acute care services to a PAC coordinator who would be given full authority to authorize, deny, and coordinate all post-acute care services for 90 days post-hospital discharge. The PAC coordinators under this legislation will be empowered to negotiate rates and saving targets with the providers. PAC coordinators, whether they are insurance or government, would keep up to 70% of any savings realized. The argument in favor of all of this legislation is that, hey, savings could be as much as 10% of all Medicare spending. Putting a rationer in such a critical position will certainly save money. There's no doubt about that. I talked with Betty on the phone at noon, and she had gotten something from a friend, some of you may know him as well, all of the acronyms. Let's see what yeah, DEF, ASAP, healthcare. Suggested as an acronym for this. But there's still a ray of hope. Co-founded by Compassion and Choices, the radical wing of the euthanasia movement, the campaign to end unwanted medical treatment, is a new coalition of 19 organizations working to determine and enforce patients' end-of-life directives. You find all stuff on the internet. Betty found a video from last summer which confirms that they know their gains can still be overturned. Here are the cautionary words of Chris Daw at one of this organization's periodic luncheon gatherings. He warns, as soon as the ACA, as soon as this feels like the worst of managed care, we all kind of know what that feels like because we've been through those experiences the last couple of decades. As soon as this feels like the worst of managed care, it will be all over. So long as we do not perceive and speak out against what they are doing, they believe they will be able to complete a full transformation of our health system. But they're still quietly scared when they talk among themselves. A couple of words on state level legislation. Recall this morning we noted that as part of last acts, Robert Wood Johnson funded an $11.25 million national framework for statewide activities called community-state partnerships. Grants averaging $450,000 were given to set up 25 statewide coalitions, often tapping into established bioethics networks. Statewide coalitions act as social entrepreneurs at the grass level. They advocate for legislation which will require professional training in palliative care, institutionalize the PULSE form, make it available electronically, increase reimbursement for palliative care, reduce restrictive requirements on paying policy boards, and mandate the honoring of patients' advance directive choices. One of them, the Carolina Center for Hospice and End-of-Life Care, got our attention, Betty's and my attention, back in 2003. A bill to criminalize assisted suicide was introduced in the legislature in North Carolina. And the CSP was working with the Center for Practical Bioethics, and they were promoting this legislation. The bill, if enacted, would have criminalized assisting another to commit suicide. However, it had 4 lengthy safe harbor exceptions, which would have legalized certain forms of euthanasia. Under the exception language in the bill, the third path, starvation, dehydration, terminal sedation scenario, could not be prosecuted. After committee hearings, 7 revisions, and much lobbying, when the bill draft then got changed to repeat language of a Michigan statute which had been enacted to stop Dr. Kevorkian. The Carolina Center for Hospice and End-of-Life Care pulled out, withdrew its support, claiming the revised legislation would have a chilling effect on pain management. That bill died in committee in 2003 and did not reappear until this spring. When a bill, on the screen, entitled "Unlawful to Assist Another to Commit Suicide" was introduced. It again contained exception language which would give a pass to the starvation, dehydration, terminal sedation scenario. The ban does not apply to withholding or withdrawing medical treatment, and understand that nowadays nutrition and hydration are considered medical treatment. So if you can withdraw medical treatment, you can withdraw nutrition and hydration. Another exception says it is unlawful to overuse medications only when the intent is to kill. Since intent is always hard to prove beyond reasonable doubt in those situations, and medical treatment is not defined to exclude nutrition and hydration, these exceptions are very large loopholes. From time to time, you might see news pieces about an organization called Final Exit Network. That's bounced up again in our area, not too in the recent past. This is a 21st century version of Dr. Kevorkian. Although North Carolina common law has declared that assisting in suicide is a crime, there will be pressure to pass statutes like the one on your screen. Its first section would criminalize the Final Exit Network. But much like the Trojan horse, its later sections exempt from criminal prosecution those whose actions hasten many deaths. Together with the PULSE paradigm, which authorizing PULSE and all of that stuff, which passed in North Carolina in 2007, this ban on physician-assisted suicide with its exceptions moved the third path toward their goal, to legalize death hastening with full immunity from criminal prosecution. Finally, the third path movement would like states to pass something called the Uniform Healthcare Decisions Act, which would replace all living will, healthcare priority, etc. legislation, and give permission to their death hastening actions in every state which passes it. And the thing about a uniform law is that it comes to each state with sort of a presumption that it must be a good thing because it's a uniform law, making its passage seem less controversial. One last thing to keep our eye on, the recently formed Partnership for Sustainable Healthcare. America's health insurance plans, Families USA, Ascension Health, the largest Catholic hospital system in the country, are key members of this group. The Washington Post recently in a story noted its key goals: making doctor payments depend on value, factor cost effectiveness into what treatment plans call for, setting better quality metrics to measure top-notch health care. They realize there will be a need for further legislation emphasizing cost reduction, and they are working to develop the political muscle to make that happen. Oh yes, Robert Wood Johnson Foundation made a grant of nearly $1.8 million to Families USA to support a multi-pronged initiative aimed to reduce the growth of healthcare spending. Quality, value, person-centered care, all of these terms have a nice ring to them. Unfortunately, in a way like the Trojan horse, they are the stated legislative goals which conceal a utilitarian-based program to allocate healthcare services based on population health and redirect those services away from individual patients and into the control of community organizations. Unless we listen carefully and speak up in opposition, our healthcare system, once based on the principle of do no harm, will be lost. As Judge Bork so aptly observed, the autonomy will be theirs, not ours.